Good morning, everyone. Today, I'll be talking about horizontal jaw relation. We'll be covering this topic in two parts. Today, we'll be covering the first part today. Now, horizontal jaw relations are those taking place in a horizontal plane of reference. It can be classified into centric relation or eccentric relation. Then eccentric relation is further classified into protrusive relation, lateral relations. Lateral relations are further divided into left lateral or right lateral. Now, the basic horizontal relationship is centric relation. It is the reference relationship that must be recognized in any prosthodontic treatment. Centric relation is the beginning of occlusion, and all treatment modalities are based on it. Other horizontal relationships are deviations occurring from centric relation. Now, they are collectively referred to as eccentric relation. Centric relation, a constant position of mandible relative to the maxilla at established vertical dimension, is a bone-to-bone relation. As you can see, the condyle of the mandible articulates with the glenoid fossa. So that is the bone-to-bone relation. Eccentric relation is variation from this centric position that occurs in anterior or lateral direction. Now coming on to the various definitions, first is jaw relation or the maxillomandibular relationship. A registration of any positional relationship of the mandible relative to the maxillae. These records may be made at any vertical, horizontal, or lateral orientation. Any spatial relationship of the maxillae to the mandible, any one of the finite relationship of the mandible to the maxillae. Now, jaw relation can be recorded either by orientation relation, vertical relation, or horizontal relation. Horizontal relation includes centric relation and eccentric relations. Eccentric relations can be recorded by protrusive record or lateral records. Now, the various definitions of centric relation have evolved through the various years. Now, in 1956, the definition given by GPT-1 was the most retruded relation of the mandible to the maxillae when the condyles are in the most posterior, unstrained position in the glenoid fossae, from which lateral movements can be made at any given degree of jaw separation. Then in 1968, GPT-3 describes centric relation as the most retruded physiologic relation of the mandible to the maxilla, to and from which the individual can make lateral movements. It is a condition that can exist at various degrees of jaw separation. It occurs around the terminal hinge axis. Now you can see that initially GPT-1, GPT-3 describes centric relation to be the most retruded position. Now according to GPT-4 in 1977, centric relation was defined as the jaw relation when the condyles are in the most posterior, unstrained position in the glenoid fossae at any given degree of jaw separation from which lateral movement can be made. Then in American Equilibration Society in 1977 challenged the RUM position. RUM is rearmost, uppermost and midmost, as it was considered to give pressure on the retrodiscal tissue at the bilaminar zone. As you can see in the posterior to the condyle, there is a retrodiscal tissue. So the RUM position was believed to have pressure exert pressure on this retrodiscal tissue. So the American Equilibration Society proposed the most anterior and uppermost position of the condyle opposite the slope of the articular eminence. This is the posterior slope of the articular eminence, and the condyle was believed to be in the most anterior and uppermost position. That is the antero-superior position opposing the slope of the articular eminence. Now, in 1987, GPT-5 defines centric relation as a maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in the anterior superior position against the slopes of the articular eminences. Now, this position is independent of tooth contact. This position is clinically discernible when the mandible is directed superiorly and anteriorly and restricted to a purely rotary movement about a transverse horizontal axis. Now, this definition explains the position of the condyles articulating with the thinnest avascular portion. So, as you all know, the articular disc is biconcave. It is thinnest in the intermediate portion and thick in the anterior and the posterior regions. So, according to this, the condyles articulates with the thinnest avascular portion of the disc, and with the whole complex, means the condyle as well as the disc together are in the anterior superior position against the slopes of the articular eminences. Okay, and this is independent of tooth contact, and it can be clinically discernible when the mandible has to be directed superiorly and anteriorly, and here only pure rotary movement occurs about the transverse horizontal axis. Now, the GPT-10 again refined the previous definition in 2023 and defined it as a maxillomandibular relationship independent of tooth contact in which the condyles articulate in the anterior superior position against the posterior slopes of the articular eminences. In this position, the mandible is restricted to a purely rotary movement. From this unstrained physiologic maxillomandibular relationship, the patient can make vertical, lateral, or protrusive movements. It is a clinically useful, repeatable reference position. See, this is the transverse horizontal axis, which extends from one condyle to the other. And along this axis, there is pure rotation, which is occurring in the centric relation position. Now, the next is the centric occlusion. Now, the occlusion of opposing teeth when the mandible is in centric relation. They may or may not coincide with the maximum intercuspal position. Now, it is basically the occlusion of the opposing teeth. We have to see the position of the condyle when the condyle is in the centric relation position. That time, whatever is the occlusion of the teeth is the centric occlusion. That may or may not coincide with the maximum intercuspal position. As you can see in this, the condyle is in centric relation, but not in centric occlusion. And here the teeth are in centric occlusion, but the condyle is not in centric relation. Now, the terminal hinge axis or the transverse horizontal axis, it is an imaginary line around which the mandible may rotate within the sagittal plane. Then the maximum intercuspal position or the maximum intercuspation, it is defined as the complete intercuspation of the opposing teeth independent of the condylar position. It is sometimes referred to as the best fit of the teeth regardless of the condylar position. Now, what is the significance of centric relation? It is an ideal arch-to-arch relationship and an optimum functional position of jaws for the health, comfort, and function of the temporomandibular joint and the musculature. The next, it is a mandibular position where the condyle assembly is seated in the anterior superior position against the posterior slope of the articular eminence. Then centric relation of mandible is a hinge position. In centric relation, condyle exhibits only pure rotation without any translation. As we have already discussed earlier, there is only pure rotation around the centric relation position, and there is no translation. Mandibular movements return or terminate in the centric relation, a reproducible position, and therefore serves as a reliable reference to develop centric relation in artificial dentures. Now, since it is the movements of the mandible start and terminate in the centric relation position. It is the home position basically. Therefore, it is reproducible, and therefore it also serves as a reliable reference to develop centric relation in artificial dentures. And it is a position where upper and lower teeth are braced against each other during deglutition. Now, it serves as a reference position for occlusal reconstruction in dentulous situations. Now, since it is a reference position wherever there is requirement of the reconstruction of the occlusion in case of full mouth rehabilitation in dentulous patients, it serves as a reference position. It is a posterior border position and the posterior limit of the envelope of mandibular motion. Now, there are two dimensions of centric relation, also called as dual centric. One is the condylar centric position, which is a condyle disc fossa eminentia relationship. Condyle disc fossa eminentia relationship, and the mandibular centric position, which is a maxillomandibular relationship. This is the condyle disc fossa eminentia relationship. And this one is the mandibular centric position, which is just the maxillomandibular relationship. Now, during centric jaw relation position, condyles are seated in the superior anterior position and not in a retruded position, whereas the mandible is in the posterior terminal position directed anterior superiorly. Now, unless the mandible functions from its terminal position, it cannot be a reproducible and consistent position. Now, what is the difference between centric relation and centric occlusion? So, centric occlusion, as we have learned earlier, that it is the occlusion of opposing teeth when the mandible is in centric relation. Now, the understanding of centric relation is complicated by failure to distinguish between centric relation and centric occlusion. Now, centric occlusion is a tooth-to-tooth position, whereas centric relation is bone-to-bone relation. Now, centric relation serves as a reference position or baseline to nomenclate the various occlusal positions. Both may or may not be identical to each other. Now, as you can see in this figure, the condyle is in centric relation, but not in centric occlusion, whereas the teeth are in centric occlusion, and the condyle is not in centric relation. Now, in persons with natural teeth, both centric relation and centric occlusion exist. Now, after the removal of teeth, centric occlusion is lost, while centric relation remains and serves as a reliable guide to develop centric occlusion in artificial dentures. Now, in dentulous individuals, occlusion and centric relation, that is the retruded contact position, is not and need not be centric occlusion. Although it would be ideal to have centric occlusion at centric relation. It means that in centric relation, the teeth may not be in complete occlusion. Okay, but it would be ideal to have the centric occlusion at centric relation. However, in edentulous individuals, it is feasible that centric relation and centric occlusion are made to coincide since there are no teeth. So we can, in the artificial dentures, we can make centric relation and centric occlusion coincide with each other. In natural dentition, tooth interferences in centric relation initiate impulses and responses that direct the mandible away from the deflective occlusal contacts into centric occlusion. Why? Because the teeth have periodontal ligament. Now, because of the periodontal ligament, there is some amount of proprioception which is available. So because of that, any interference in the tooth will initiate that impulse, and they will send a response to the brain that the mandible will be deflected away from those deflective contacts, and the patient will go into centric occlusion. Now, impulses created by the closure of teeth into centric occlusion establish memory pattern that permits the mandible to return to this position without interferences. When this happens, there is a memory pattern which is created, and the individual knows that where there is interference, he need not close on that. He will change that position automatically. Now, when natural teeth are lost, many receptors that initiate impulses resulting in positioning of the mandible are lost or destroyed. Now, in edentulous individuals, they cannot control mandibular movements or avoid deflective occlusal contacts in centric relation in the same manner as the dentulous patients can. Now, deflective occlusal contacts in centric relation may cause movement of the denture bases and displacement of the supporting tissues and direct the mandible away from the centric relation. So, the centric relation must be recorded for edentulous patient so that centric occlusion can be established in harmony with centric relation. This can usually be achieved with centric relation and centric occlusion coinciding in artificial dentures. Now, next, we come on to the concepts and objectives in recording the centric relation. First is minimal closing pressure so that the tissue supporting the bases will not be displaced while the record is being made. The objective of this concept is for the opposing teeth to touch uniformly and simultaneously at their first contact. Now, the uniform contact of the teeth will not stimulate the patient to clench and relax the closing muscles in periods between mastication. Another concept is the heavy closing pressure so that the tissues under the recording bases will be displaced while the record is being made. The objective of this concept is to produce the same displacement of the soft tissues as would exist when heavy closing pressures are applied on the dentures. Thus, the occlusal surfaces will be evenly distributed over the supporting residual ridges when the dentures are under heavy occlusal loads. Now, the disadvantage of this concept is that if the soft tissues have uneven thickness, the teeth contact unevenly at their first contact. Now, uneven contacts may cause clenching in the nervous patients. Now, next we come on to the problems in retruding the mandible to centric relation. Various difficulties which can be encountered are biological problems, psychological problems, and mechanical problems. First is biological problems. It may be due to lack of muscle coordination, a lack of synchronization between protruding and the retruding muscle due to habitual centric position. This happens usually in patients with a long period of edentulousness where only anterior teeth are present. Then psychological problems, both patient and dentist play an important role in recording the centric relation. Now, more the dentist becomes irritated, more confused will be the patient, and less likely the patient will respond to the direction provided by the dentist. Then third point is the mechanical problems that may be due to poorly fitting base plates, unequal pressure due to unequal resiliency of the tissue because of the varied thickness. Then there may be problems in processing where there can be unavoidable human errors where the centric relation might be lost. So these are various problems when the centric relation is recorded. Now, what are the various methods to instruct the patient to retrude the mandible? So first is you have to instruct like let your jaws relax, pull it back, and close slowly and easily on your back teeth. When you tell the patient, now get the feeling of pushing your upper jaw out and close your back teeth together. Now, telling the patient to move his upper jaw out will automatically move the lower jaw back and the patient can then repeat it. Now, instruct the patient to protrude and retrude the mandible repeatedly while the patient holds the fingers lightly against the chin. The movement into the desired position can be felt by the patient with the patient's own fingers on the chin. The dentist can aid by a slight pressure on the point of the chin. Now, instruct the patient to turn the tongue backward towards the posterior border of the upper denture and close the rims until they meet. Now, instruct the patient to tap the occlusal rims or back teeth together repeatedly. Tapping the occlusal rims or back teeth together rapidly and repeatedly is used to help the patient retrude the mandible, since it is believed that the center of muscle pull will gradually work the mandible back. However, it is difficult to record these positions, and a patient can easily tap in a slightly protrusive or lateral position. So, this should be checked with other tests. Another point is to tilt the patient's head back while the various exercises just listed are carried out. Often, tilting the head backward at the neck will place tension on the inframandibular muscles and tend to pull the mandible to a retruded position. However, it is extremely difficult to obtain registrations with the head in this position because of the awkwardness of insertion and removal of the recording medium and occlusal rims from the mouth when the head is so tilted. Then palpate the temporal and masseter muscles to relax them. The temporal muscle shows reduced function when the mandible is in a protruded position. Now, for this reason, its contraction can be felt when the mandible is in or near its retrusive position and the patient is asked to open and close. Massage or palpation of the masseter and temporal muscles will help patients to relax. Another method can be asking the patient to swallow. Then there can be boost series of stretch exercises which can be instructed, such as open wide and relax, move the jaws to the left and relax, right and relax, forward and relax. And Dawson's bimanual method. From here, we will cover in the second part. Thank you.